Hi. So my topic is about stem cell technology in breast augmentation. Of course, lipofilling. If we want optimal processing, we need to maximize viability of cell and tissue, minimize detrimental cells, agent, and additives, enrich critical cells, and of course make it bioavailable, optimize water content, close system if it's possible, and minimize the variability. Why add stem cell and progenitor cell? Because all of them give us all this kind of action: wound remodeling, blood supply, prevention of cell death, harm to injury, immune modulating, paracrine signaling, and differentiation. So they're very important. And a key advantage to stem cell technology is cell number. From 100 cc of adipose tissue, we can obtain 100 more regenerative cells than from 100 cc of bone marrow. Using myself, for example, I weigh 78 kilo and I'm 180 centimeter high. I have approximately 15% body fat on me. This translates into perhaps 5-6 billion regenerative cells located inside my fat compartment. There is no other source of such plentiful stem cell in our body. And if we see the number of this regenerative cell that we have in the fat, in 100 cc we have 40 million and so on, 280 million. And if we look at what we arrive to have from the device, I will show you later, solution that is from Satori, we have a lot of stromal and endothelial precursor cell, a smooth muscle-related cell, of course also endothelial cell, adipose-derived stem cell, and hematopoietic stem and progenitor cell. If we see what happened when we use the fat enrich, you will see the difference in terms of fibroblast, of pre-adipocyte, of endothelial precursor cell, of mature endothelial cell, instead of centrifuge normal fat like Coleman technique and with solution. And again, we see the difference in the growth factor, how much are present in the fat with cell enriched and in the normal centrifuge fat. This is the device solution from the Satori that I use and I show you, and I will use in 1 hour in the operating room to perform a case of breast augmentation. And here we can see the disposable kit, the instrument, the enzyme cellase we can use to digest the fat, and of course this cell brush that is very useful to inject the fat. This is the way we have to do to perform an injection of fat enrich. So we start with the adipose tissue, liposuction. With the lipoaspirate, we have to digest it in the device during the operation, and we put the cellase enzyme. We arrive to the pure regenerative cell. We add another part of fat, washed fat, and we arrive to obtain our cell-enhanced fat grafting. The evaluation in 6 and 9 months, again, distinguishes Coleman fat only and enriched fat, show us how the percentage of survival change, like the double, and also the capillary density is like the double, but we have less cyst and vacuole scoring and less percentage of fibrosis. Here we see the step we will do also today in the operating room. The nurse is putting the kit, disposable kit, in the machine. Here the machine is ready, so we do the liposuction, and here you see with the 60 cc Luer locker syringe, here is the fat decanting from the nurse, and the fat is collected into the box of the machine. We use everything, all what we lipoaspirated, and again, we put, when the machine asks to us the cellase enzyme, and we put in the same box. And this is needed to digest the fat and to obtain the magic mixture of regenerative cell. Here you can see a phases of the centrifugation in the machine of the cells, and here the nurse remove the fat digested. So this is not able, and we put another part of the fat, the second phase is another fat that is washed from the machine, and we wait for the mixture of this kind of regenerative cell. We remove 5 cc each time, even if we can put in the machine different amount of volume. The minimum is 100 and the maximum is 360. Here we mix the cell with the new fat, and we are able to harvest the fat that is ready to be injected. The last thing you see, the nurse is preparing the cell brush, and this is very useful instrument with the 10 cc lock syringe. We pass the fat from the 60 cc lock syringe in this one that is ready to inject the fat. Of course, with this technique, we need much more fat than the Coleman technique or other technique, because the first part of the fat is digested from the device, and we put another part. Normally, it's 1-to-1. If I digest 200 cc, I put 200 after to enrich. And the maximum, as I told you, is 360. But we need so a lot volume and a lot time to obtain this. Of course, we do incision of number 11 blade for the liposuction, and for harvesting I use 60 cc lock syringe just before to infiltration with clean solution. Here is a case of asymmetric breast augmentation, hypoplasia, and here you see the right breast is a little bit more than the left. This is the project: abdomen, internal thigh, flank, sacrum, and knee. These are the normally the area where I harvest the fat in the majority part of the cases. And these are the gateway I use, and I do with a trocar to do the infiltration of the fat. 4 periareolar and 3 in the submammary fold. This is the cases, and the the cases was done with the liposuction of 2 liter and 200. And here you see the amount, in all the cases I show you today, the amount of solution enriched fat, and also another part of normal fat, not enriched, that I use in another layer. Normally I use a superficial layer, the enriched fat, and in the deep layer, subglandular or submuscular, the other fat. Here you see the space where I inject the fat, subcutaneous space, every time, and normally I use the enriched fat, between glandular and pectoral, and also submuscular plane. Here you see the 2 different layers where I inject the fat, and also you see the cell brush that is very useful and is very nice, because you can moderate the quantity you inject using 10 cc, and it's very nice. This is a case of breast lipodystrophy, HIV related, with a patient with a lot of fat to harvest, buffalo hump, back, and 2 big lipoma in the upper pole of the thoracic and the breast. And here is the result at 9 months post-op, with only 180 cc with fat enriched and 220 cc each side, deep layer in this breast. Of course, this is a big liposuction with 2 liter of normal liposuction, and I harvest also 2 liter and 60 with ultrasound, because they are very a lot of fibrosis. And here you see the follow-up at 14 months, how the result is stable, and how is the... So this is another breast hypoplasia mammary. This is the program, and not a lot of fat, also a pectum excavatum. So I need to put to inject fat in the pectum excavatum. I use 40 cc of fat for the pectum excavatum, of enriched fat, liposuction of 1 liter 60, and here you can see the result, especially in the lateral view. This result is not too much, but it's enough with this lower fat area, and here is the result of pectum excavatum.